Welcome to the Global Hemophilia Report, a podcast at the intersection of science and storytelling. I'm your host and resident person with hemophilia, Patrick James Lynch, joined as always by my colleague and our senior scientific advisor, Dr. Donna DiMichele. This program is produced by Believe Limited and Bloodstream Media and made possible thanks to our featured advertiser, Sanofi. Today we're returning to a conversation that's long overdue about who gets seen, who gets believed, and who gets left out. It's a conversation about women with hemophilia. Over the past decade, our understanding has grown. Now we have clearer language, more accurate data, and better definitions that finally reflect the reality that, yes, women do indeed have hemophilia. And yet, the gap remains. Women are still waiting years for diagnosis. They are underrepresented in clinical trials. And when it comes to treatment safety and reproductive risk, they're often left navigating blind.
So when I started in obstetrics many years ago, women were carriers. Men had hemophilia, women were carriers. There were no women with hemophilia, regardless of their symptomatology.
Probably about 1 in every 5 mild hemophiliac is female. And so I think that just kind of helps people understand the sort of potential for this.
We are beginning to bring to focus the female experience beyond the experience of passing down a gene, and acknowledging that individuals may be experiencing bleeding symptoms.
If you are brave enough to start talking about your symptoms and you are dismissed or you are gaslighted, it creates shame and embarrassment. And that's really hard to overcome than the next time or in even more serious bleeding situations. So it makes us kind of stuff all that down.
It's frankly egregious, it's unethical, and it's contributing to a patient's experience of trauma.
In this episode, we ask, how far have we actually come? What's still missing from the science? And what will it take to ensure that women with hemophilia are no longer a medical afterthought, but a clinical and community priority? We'll explore those questions and more with our expert panel right after this.
Sanofi seeks to break barriers for people with hemophilia through groundbreaking science so they can live beyond the limitations of their condition. Learn more about Sanofi's commitment at redefininghemophilia.com.
For years, the language around hemophilia reinforced a binary. Men have it, women carry it. But this framing is no longer scientifically tenable. Recent analysis shows that up to 20% of females in national hemophilia registries meet factor-level criteria for a hemophilia diagnosis. Yet many continue to be labeled as mere carriers. Diagnostic delays are common and symptom severity often doesn't align with factor levels, further muddying the clinical picture. Even today, more than 40% of symptomatic women experience diagnostic delays exceeding 5 years, underscoring a systemic gap between evolving science and clinical practice.
As time evolves, of course, we're learning that individuals who are symptomatic now seems to be up to 40% of individuals. When I started working in this field, it was thought to be 20 to 30%. I'm Michelle Sholzberg. I'm an adult hematologist at St. Michael's Hospital in the University of Toronto in Toronto, Canada. And I'm the director of hematology for the University of Toronto as well. And I've held leadership roles in the past, including past president of the Association of Hemophilia Clinic Directors of Canada.
And a special interest in women's health and hemophilia.
I certainly do. My entire research focus is on the topic. You got it. A good proportion of individuals who are considered carriers, which historically in medicine, a carrier means you don't have the disease, you're just carrying the genetic mutation that predisposes future generations to develop the quote unquote disease or disorder. So that's a challenge. So individuals who are carriers can in fact be symptomatic. And also, as we know, there are individuals who can have symptoms and also have low clotting factor activity levels. So I think another big piece there is the change in nomenclature, which I think is really, really important. Language really matters.
So the first descriptions happened in the 1950s. There was a little bit of data that came out in the 1980s, some commentaries about it. I'm Robert Sidonio Jr. I'm a pediatric hematologist based out of Children's Healthcare of Atlanta at Emory University. And, really the early part of my career was focused on adolescent girls and women with bleeding disorders. But it really wasn't until, 2021, it wasn't that long ago, before we really decided that we needed to wrap ourselves, we needed to figure out how are we going to sort of use these labels if the way that we talk about this group isn't clear and is sort of ambiguous, then it's just not going to be very good. We're not going to have very good science and it's going to be difficult to communicate. And in the US, everything comes down to billing. And so if you don't have proper labels and you don't use this, you're not going to get compensated. And, people are going to be left with big bills. And so we came up with a simple system. We said, certainly women can definitely experience hemophilia. They can have severity levels that are in the hemophilia range.
While we know the nomenclature was updated in 2021, it takes real effort to undo 200 years of misinformation. I'm Donna Rotellini. I'm the Chief Operating Officer for the National Bleeding Disorders Foundation, and I also am a board member for the World Federation of Hemophilia, and I chair the International Women and Girls with Bleeding Disorders Committee. So we're kind of swimming upstream here. And I agree completely with Michelle that there's also a big part of us as women who are carriers and some who have hemophilia, some like myself who have been diagnosed as a symptomatic carrier at the age of 59, finally. After experiencing a lifetime of symptoms, it was never, ever about me. It was always about either my father or my son, because they had so much worse outcomes and symptoms than I ever even realized in myself. I didn't even see them. I knew I had heavy bleeding. I knew I had nosebleeds. I knew I had prolonged 2 weeks of bleeding after dental work, those kinds of things. And then, of course, once I hit puberty, heavy menstrual bleeding. All of that was just my normal. It wasn't recognized as abnormal, not by my pediatrician, not by my doctors as I grew up. And so I think that because we were told women can't have hemophilia, we were like, whoa, thank goodness. Can you imagine how bad I would be bleeding if I did have hemophilia? So I think that this, all of the nomenclature change can't undo that overnight.
I wish that I could sit here and say that, the narrative that Dawn has just shared is something that I haven't heard before. I wish that I could say that I haven't heard something similar from so many other patients.
So the burden of hemophilia for women, as we know, it stretches far beyond physical symptoms. According to one global survey, 88% of women with bleeding symptoms report being dismissed or not believed by providers.
Dawn, I think you've really eloquently described repeated episodes of healthcare-related trauma, which is horrific. The term medical gaslighting almost doesn't even begin to quite cut it, because the gaslighting piece is so important, because it's saying, you're crazy, your experiences aren't real, but then additionally, and because of that, you are not going to get the care that you deserve. So it absolutely negatively affects acute, short-term and long-term outcomes.
In our society, we don't second guess doctors. We're raised to not push against the expert. And so when you are gaslighted, it makes you second guess yourself. It makes you think, oh my gosh, this must be in my head. This has been going on in all of women's health. And so when that happens, it just leads you to be quiet, to suck it up, rub dirt in it, and the accumulation of not being recognized for your bleeding, of, subclinical or micro bleeding. You don't even talk about that. You're really only bringing up major bleeding issues that are really impacting your quality of life. And I think, Patrick, at the end of the day, what that leads to is a really poor quality of life, anxiety, depression, and management of a disorder that no one believes that you really have.
And in fact, we've found, along with data from others, that hemophilia carriers are likely to underreport bleeding events, as opposed to the historic notion, which was not based on scientific evidence, that carriers over-reported bleeding symptoms because they were exposed to bleeding in their household. I can say, as a woman and a mother, it's not surprising that mothers are likely to underreport and minimize their experiences because they're often focused on the experiences of their children.
When my son was a baby and we were navigating his hemophilia care and treatment, I was told by a nurse, and this really resonated with me, and it made me never speak about my own bleeding until only in the last 5 years. And that was, I hate these hemophilia wannabe moms who are in our clinic. They bring their babies in, they exaggerate their own symptoms, and they distract from our care of their children. I was told that as a new mom by a nurse in a hemophilia clinic. And it wasn't my clinic, so I will say I was at a conference and sitting with some healthcare providers, and she said that, and I went, oh, I will never be that mom. I will never be, right? Being this compliant, I want the best for my son. This is part of that decades, centuries long dismissal and the stigma for women.
Health equity starts with understanding. Meet Shelley, a woman whose hemophilia diagnosis challenged stereotypes and inspired her to drive change. After years of unanswered questions, Shelley's story highlights the power of health literacy to close care gaps and uplift underserved communities. Scan the QR code or click the link in the show notes to watch her inspiring journey and learn how health literacy transforms lives.
It doesn't even begin to deal with the stigma and shame that talking about things like heavy menstrual bleeding bring in cultures, in society. It doesn't address the dismissal of women and their symptoms by the healthcare community over all these years.
The reproductive risks are especially striking. Studies show women with hemophilia experience higher rates of postpartum hemorrhage and miscarriage, yet clinical guidelines still lag in addressing these needs.
I'm Dr. Andrew James. My nickname is Andy. I'm Professor Emeritus in the Department of Obstetrics and Gynecology at Duke University and Consulting Professor of Medicine in the Division of Hematology there. I'm also a co-founder and still chair of the Medical Advisory Committee of the Foundation for Women and Girls with Blood Disorders. My particular specialty is obstetrics and gynecology, and I see women and girls with hemophilia coming into the medical arena through obstetrics and gynecology. I don't know how well we can educate obstetricians and gynecologists who will only see one or two hemophilia carriers in their entire career. But when these women become pregnant, they all recognize that hemophilia is an X-linked disease and refer them to a genetic counselor. But they can also then recognize that there are bleeding risks to the mother and to a potential unborn baby, and they can be point people to make sure that a hematologist is involved, maybe for the mother, maybe for the baby, because every pregnancy that involves a woman or with hemophilia should also include a plan for the mother. Does she need to be treated? And a plan for the baby. Does the baby need to be treated? And so that also means getting the patient referred to the right team at the right institution. And I think this was brought home to me by a young woman who knew that her uncle had hemophilia. She told that to the obstetrician gynecologist. She herself had no bleeding history, or so she thought. And yet the obstetrician gynecologist knew enough to refer this patient to the genetic counselor, who counseled the patient about the inheritance risks, but didn't help the obstetrician gynecologist make a plan for the mother and the unborn baby at the time of delivery, and the baby suffered an intracranial hemorrhage. So there was a missed opportunity. There was a recognition that maybe something should be done, but and the genetic counselor addressed the narrow inheritance risks, but didn't get the big picture.
You know, we can't just preach to the choir. We got to go out to the people on the front line, and that's the OBGYN docs. And they know, I mean, all the fellows know in my clinic, if they're coming to my referral clinic, they're going to see at least 3 or 4 girls with heavy periods. That's going to be the referrals that we see. And so I think that's where it needs to start, you know, and making the gynecologist comfortable. There have been so many times where I see on the chart, they're not, the GYN is not comfortable seeing anybody under 16. It's sort of an artificial, sort of barrier.
So what data sets or registries are currently doing the best job of capturing accurate prevalence and phenotype data? And as a nuance in that question, does that data include things such as the mental and emotional health toll that the bleeding disorder takes on the individual?
I'm a professor of pediatrics at Rush University Medical Center in Chicago, and I am focusing this part of my career on trying to achieve equitable outcomes for all people living with bleeding disorders. I'm not sure that we really have good numbers on the prevalence of hemophilia in women and girls of all severities. Obviously, the most severe cases are the ones that are seen in hemophilia treatment centers. The more mild cases and certainly moderate cases that I think we're still missing to a great degree. And we don't have a good estimate as to how prevalent those cases are. We have estimates based on genetics and other calculations, but I think real hard numbers are lacking.
The challenges of it are hard because, you know, we always joke about this. It's easy to do a study in severe males with hemophilia. They're all males. They all have the same level. They have generally the same bleeding phenotype. So it's real easy. You just give them a drug. You count the bleeds before, give them the drug, and count the bleeds after. It's real simple.
I think we have to acknowledge that when we are testing patients, that we are testing them in a static state, and that may not necessarily represent their dynamic ability to respond to stress or hormone release or clotting factor activity levels in key locations that we may not be able to measure.
I did, in a presentation at an international conference, I did share that I had 4 different levels of factor. And I am a carrier of hemophilia B, symptomatic carrier of hemophilia B. And I've had 30%, 60%, 78, and 88, the 4 times that I've been tested, not in that order. But I was told that was absolutely impossible, and that they wanted to know which assays were used and by which labs, and were they consistent through my life that I went to the same lab, because that can't be right. And I should stop spreading misinformation.
So in 2023, following the ISTH definition for women and girls with hemophilia, we wanted to look at how well was that definition potentially being followed by inclusion of women and girls in clinical trials. So in 2023, we searched the clinicaltrials.gov database for clinical trials that included women and girls. And we were able to identify 124 trials that were available with results that we could analyze. And surprisingly, we found only 6 of 124 trials, or a little bit under 5% of those trials, included at least one female participant. Now, you might think that, well, that sounds pretty good, that at least you have 5% or so of women. But if you break it down into the total number of participants, which was more than 7,500 participants, less than 0.1% were women or girls. So you really have this very, very small number of participants. And the nuance of that number, so that was 8 out of more than 7,500 were women and girls.
We have absolutely no idea how prescribed medicine that has only been tested in men interacts with our hormones, with our organs, which are different.
So I think there needs to be a clear emphasis on enrolling women and girls into clinical trials, that we need to do this purposely, and it can't be, a secondary or afterthought.
Certainly these research barriers go back to this gender bias, excluding those who could become pregnant in any trial, because that could really mess up your trial. Structural factors like not offering daycare when you do clinical trials, for people who are taking care of children at home, that can be a barrier. Not thinking about what is the construct of the clinical trial where we could just remove some barriers and allow for females to participate. I mean, there are all of these things that males don't actually have to go through with the barrier. So, I mean, I think what we could learn from including women and girls within these trials is the role of hormones. How does all of this impact menstruation? What happens to your body when you're menstruating? The different hormones. Lack of willingness to include heavy menstrual bleeding as an actual symptom. That's actually an issue.
I think that there really should be the development of prospectively collected data, really using accurate measurements of vaginal blood loss in particular for females that are affected with hemophilia. Another part is that we owe in research females with bleeding disorders and females in general outcome measures that are just as accurately defined as outcome measures that are available for males. What I'm referring to is, for example, really up until very, very recently, the ways that we would measure vaginal bleeding is appallingly flawed.
One of the challenges is what is our primary outcome? And I mean, the alkaline hemotin method is still the gold standard, but is very impractical. I remember visiting in Houston, and Dr. Brown was there, and she was carrying this big dark plastic bag. And I was like, what's in there? And she's like, you know what's in there. So, collecting those pads, shipping them to the person, the physician having to buy all of the same pads, hopefully from a similar lot. There's just so much variability from that.
Counting heavy menstrual bleeding as a bleed, knowing how to quantify it. I think that's really important without having to bring in your used pads and tampons, which still happens, or coloring a picture chart to prove that you're actually bleeding. Treating for phenotype versus waiting for a level. Saying, oh, you're experiencing this kind of bleeding. Let's actually treat you so that we can get you to a point where this isn't impacting your life so negatively.
Teenage girls with heavy menstrual bleeding and bleeding disorders have a dramatically lower healthcare-related quality of life that is akin to a male with severe hemophilia and HIV positivity.
Back when it was first described, if females did have bleeding that was abnormal, they were deemed to be hysterical. It was a medical fact that women could not have hemophilia. And of course, now we know that that is absolutely not true. That has been a huge barrier for women and girls to this day of getting accurate diagnosis and access to care and treatment. Women and girls are not included in clinical trials. And the issue is that if women are not included in the data, that door is never open for them and they don't get access.
I've talked to many women that even can't get doctors, can't even get diagnosed. I want the future generation, especially for women with hemophilia, to be treated the exact same. We've never done this before. We have never collectively come together to talk about what it is like to be dismissed.
But I want to ask a question about how do we truly get to a future where women have equitable treatment and care for hemophilia? And I want to ask that with respect to something that was brought up in our conversation about how we are doing a good job of reaching the providers who need to know. But how do we get beyond that? How do we get to that next group of providers?
A number of papers out there that sort of have outlined some of this issue, but what we really need is some sort of long, this is the kind of stuff that's difficult. You need like 10, 20 years of following this cohort and collecting this data on a regular basis. And of course, this is where the CDC would have been really nice. And we actually had some data that we were going to secure before the beginning of the year. And of course, that data is not available to us right now.
The other part is when recruiting for a hemophilia trial, and this popped into my head, is that when you say, I've had a couple of manufacturers since I started talking about this openly over the last few years, they've said, hey, I wanted to let you know we're including women in our clinical trial. And I'm like, oh my gosh, that's amazing. How did you word it? And it was open to people with hemophilia, moderately severe to severe. And I said, well, that's great. No one is going to think of a female because you weren't specific, because we have the bias. We have to overcome the bias and use words. Words matter, right? Language matters. And we have to purposefully recruit females in order for any healthcare provider to even think, oh my gosh, I do have somebody that might be really perfect for this trial.
Research prioritization is largely driven by the market and by politics as well. In all of women's health related research, there are far fewer opportunities for research funding, I can say definitively in Canada, than there are for conditions that either predominantly or solely affect men. So it's an example of structural sexism. I think it's important to acknowledge that when you don't have opportunities for, governmentally linked peer review funding, which can be very difficult, especially in rare disease spaces, that you're largely dependent on the agenda that is driven by our industry partners, which sometimes can be incredibly helpful, but sometimes can be challenging because, again, the agenda is being driven by the market. And so, it's understandable in many ways why the agenda has largely focused on males with hemophilia, because that was the majority of people who've been provided treatment. So it becomes sort of like this self-fulfilling prophecy of the market is driven by the men, so let's include men in the clinical trials because the market is driven by the men, et cetera, round and round and round.
We've got to start asking females about their symptoms from known families that are affected. We need to start asking that, whether they have a clinic visit or not. If they're in the waiting room, let's go have a conversation and ask them about their own symptoms, because I'll bet you no one's ever asked them.
Cedric Herman's research group did a great example of this and published a nice paper where they contacted every single woman that was connected to all of their males with hemophilia, which, I cannot imagine what an undertaking that was. And they were able to identify a lot of these patients that had deficiency.
So we use these very vague outcomes, which leads us to have very vague estimates even of the prevalence of certain symptoms that women experience. I could not imagine a similar experience for males, for example. Like if we were talking about heart disease, it's almost unfathomable for us to say, oh my gosh, could you imagine if we didn't have clear definitions of XYZ outcomes related to, heart attacks, for example, or something like that. We would just say, that's crazy. Like, of course we have to develop this really validated, accurate outcome measure so that we can be absolutely clear that we're measuring what we're intending to measure and that it clearly correlates with additional variables and outcomes and et cetera. And we just haven't done that in women's health.
What I learned from our participants was the outcomes fall into two categories that we need to be looking at. One are actual measures of blood loss, something that is usually visual, either using spectrophotometry like the hemoglobin alkaline test, alkaline hematine test, or a pictorial blood assessment chart, something that tries to get out what is the actual blood being lost. And the other category is some indirect measure, like hemoglobin or a ferritin or something else. I think that there might even be something new that we haven't thought of that we could use that might be even better, or some outcomes that an outcome that incorporates multiple measures.
I think that prospectively collected registry data could massively serve the community and the research agenda, massively. There are some large registries that are beginning to be developed, but I'm not aware of many, and I would love to develop something in Canada, ideally, that would gather the types of outcomes that would be of interest.
We need to start testing at birth. We need to start counting women, including all carriers, in a data set. Let's just start automatically counting all the carriers. And so that we actually start with this robust data set, then we can start to ask questions, even through surveys and non-interventional studies, to ask what are these different bleeding experiences for you?
I mean, the HTCs were set up to see severe hemophilia. So males with severe hemophilia. That's what they were set up initially for. They've obviously expanded past that. And so we just need to go back and take a look at our structure and say, how can we make this for all bleeding disorders, and make sure we have those resources? Having a gynecologist shouldn't be just some sort of, niche thing. It should be standard. It should be like having a physical therapist or having a research coordinator. It should just be standard. And so I think just looking at what resources we need to make sure we have an HTC that's inclusive, because the growth in our clinic is predominantly women. It's predominantly teenage girls. We certainly get new patients with males with hemophilia, but we get way more patients that are adolescent girls with bleeding disorders because we're trying to do better at identifying them. So we just really got to go back to that infrastructure and reevaluate, is this what everybody needs?
We see so many changes in the way men with hemophilia are being treated, and how the requirements for staffing of hemophilia treatment centers is evolving, and the thinking is changing. I think as part of thinking about how hemophilia treatment centers serve the needs of the community, it's not only about how we use and incorporate new drugs and treatments into it, but it's how we include new populations like women and girls, the LGBT community, into the hemophilia treatment center model moving forward. So I think that's, we're only focused on, how do the new drugs impact staffing and what are the needs in the future because of the new drug treatments. But I think we should be thinking about new treatment populations as well.
If I may, if I can read a small paragraph, because I think it'll answer the question, because I think that our way forward is through humility. So I'm going to read this. This is from a paper that was published in the Journal of Diagnosis in 2019 by Drs. Wu and Lowenstein, and it's entitled Balancing Confidence and Humility in the Diagnostic Process. Humility in medicine can be difficult to achieve, yet arguably is one of the most important competencies to master. Overconfidence, on the contrary, is a natural tendency, having established its roots in evolution, where quicker and more confident decisions likely conferred a selective advantage. Humility may evoke an image of weakness and vulnerability antithetical to contemporary medicine, whose culture is dominated by overconfidence. Nevertheless, humility can be learned and is important because overconfident behavior can be detrimental to our patients medically, psychosocially, and legally. To practice humility requires strength and emotional resilience. So that's why I think it's the way forward for all healthcare providers. Treating all patients, _all, with bleeding disorders.
If today's conversation has made one thing clear, it's that progress isn't the same as equity. We've come a long way in acknowledging that women can have hemophilia, but acknowledgement without action still leaves too many behind. Diagnostic delays, trial exclusion, treatment unknowns, these are not just oversights. These are the direct result of systems that were not built with women in mind. And the cost of these gaps is not theoretical. According to recent data, nearly half of all women with hemophilia report experiencing a major bleed before receiving an accurate diagnosis. That is not just a missed opportunity. That is a failure of care. It's on all of us, clinicians, researchers, regulators, advocates, and industry partners alike, to do better, to ask harder questions, to collect better data, to center women's experiences not as exceptions to the rule, but as part of the rule. So let this be a line in the sand, not just a conversation, but a commitment. Thank you to our guests for their insights and to you, our listeners, for your time and attention. Thank you to our featured advertiser, Sanofi, without whom this discussion would not have been possible. This has been the Global Hemophilia Report. My name is Patrick James Lynch, and until next time.
Sanofi is committed to bringing new perspectives and bold innovations to the global hemophilia community. Learn more about how Sanofi is committed to breaking barriers and supporting the community at redefininghemophilia.com.